Hello, everyone. So go ahead and get comfortable. We are in for it, okay? This is going to be our Perio exam review, okay? So I'm going to break it down into chapters. I feel like it'll be better to learn that way, one chapter at a time. What we're going to do is we're going to kind of go through the whole PowerPoint, okay? So get all the study materials you need. Press pause if you need to, but get everything to follow along here because not all of it is terminology. Some of it's questions, so we really want to get a comprehension of what's going on. That way we can understand it chapter by chapter and apply it to our test. So it gets a little bit easier for us, okay? And this is good stuff to know. We're going to need to know it moving forward with our career anyway. So this is just really good review. So I usually use my little index cards, but I got them all mixed up. So I'm going to go off of my Quizlet. Now my Quizlets usually incorporate all of the PowerPoints, not just the ones with stars on them. I figure it's good to review some of that stuff anyway, just in case it's on board. The boards, I like to get a comprehension of all of it. So if there's some that's noted that says no star on it, I'll let you know. Not all of these are marked like that though. So there's only 42 slides. So that's nice. If we take it chapter by chapter, you know, we go over this one chapter, we get all of this information stuck in our head, we can move on to the next, you know. It won't be so hard. And this, like I said, is everything in the PowerPoint. So that way we're not missing anything, okay? And I hope it helps, okay? I hope it helps somebody. Okay, so get your stuff, press pause if you need to. Chapter 1, Perio Exam 1, okay? The first question is, how do you measure recession? I'm not sure if this will be on the test, but it's really good to know because we need to know this. So how do you measure recession? Well, let's think about this. So when we have recession, the gums recede down, right? So you want to measure that space where it should have been to where it is now, right? So where it should have been is that gingival margin, you know, is the contour around the CEJ. Remember that stuff, the CEJ? So if you have recession, what are you going to measure? You want to measure that distance that it's gone down to, right? So you're going to measure recession. You're going to measure recession from the CEJ to the gingival margin, right? The cute little pink stuff that goes around CEJ to the gingival margin. And that distance right there is how much the gums have receded. Okay? We're just going to break things down little by little. We should know this. If not, it's a great review because we're going to have to. Okay? I have a cute little picture here on my PowerPoint. See that little PowerPoint picture? It's measuring from the CEJ down to the top of the gingival margin right there. Okay, that's how you measure recession. That's looking like about 4 millimeters of recession there. Anyways, next question. Good job. Might not be on the test, but it's good to know. Okay, what is pericoronitis? Pericoronitis. 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 We can break this down. So we know itis is inflammation. Okay, pericoron right? So peri is around. So around coron inflammation. What is pericoronitis? So it's inflammation around the crown, right? Really easy stuff. I also have a picture here to break it down for you. So we know we've heard of an operculum, right? If not, we'll review that too. Operculum is like when a wisdom tooth is growing in, a little crooked, and there's a flap of skin on the back of it, on the back cusp. So this is pericoronitis. If you could see this, sorry about the lamp, but see how that gingiva, that gingiva is growing on top of those cusps right there? It's gingiva inflammation around the crown, pericoronitis, okay? Whenever you hear words like that, just break it down. You got this. You know this terminology. And what's cool is I think we're getting a medical terminology class in this semester too, so we'll learn more of those core words that help us get through those big words, okay? But pericoronitis, inflammation around the crown, okay? Next question. Now this one is not starred, however it is going to be in pathology, so we won't focus too much on this, but it's pyogenic granuloma. I know we talked about it in pathology. It's going to be in chapter 2, so we'll get into that when we do the pathology videos, okay? but it looks like this. I got a little picture there too, okay? That's pyrogenic granuloma, I believe. Yep, granuloma, pyogenic granuloma. So that little oma looking thing, that little, I guess you could call it a lesion. It's really bright red, so it looks like it's on fire. So, you know, pyromanias and stuff, bright red granuloma, you know. So what that is it's due to hormonal changes. So pregnant women, if they're pregnant, it's going to be a pregnant granuloma or something like that. We'll get into that with pathology. We're not going to focus too more on this because it's not starred, but that's just a word we're going to get familiar with. But it's a tumor-like mass produced in response to trauma. It does not produce pus. It's highly vascular and bleeds easily. And when somebody sees this, when a doctor sees this in somebody's mouth, the first thing they're going to ask is the patient pregnant? You know? So don't worry too much about that. We're going to move on. So this says explain periodontium, okay? Periodontium. So we know all of these words: gingivitis, periodontitis, periodontium. So what is periodontium, right? So periodontium, peri, right, around the tooth, periodontium, dentition, around the tooth. So what structures are around the tooth? What secures it down in there, right? The periodontium is kind of the whole thing, okay? Not just the bone loss or not just, you know, the gingiva inflammation. It is the periodontium. It's the whole thing, the whole ordeal. Okay, periodontium. It's a functional system of tissues surrounding the teeth that attaches them to the bone. Okay, so periodontium. It's a functional system. We know this. We chew with our mouths. It functions for us. It helps us do all that stuff. Keeps our teeth in there. It's functional. So the periodontium is a functional system, right, of tissues, because they're all tissues, whether they're hard or soft. So, functional system of tissues surrounding the teeth, periodontium, that attaches them to the bone, okay? Periodontium, the whole ordeal. Functional system of tissues surrounding the teeth that attaches it to the bone. Excuse me, I've had allergies today. So, what are the tissues of periodontium, right? So if we know the periodontium is all of those, you know, tissues holding the teeth into the bone, let's think about this. Let's think this through. There's 4 tissues that we're looking for that hold the teeth into the bone, right? Let's start with gingiva. We have attached gingiva that helps stick that down in there, doesn't it? So we have gingiva. We have cementum. Cementum's an important key because the periodontal ligaments attach into the cementum and they attach into the bone, right? That helps suspend it down in the socket. So boom, we just named 4 tissues, didn't we? So we have the gingiva, like attached gingiva, holds that in there. So gingiva, cementum of the root, and what attaches that? Periodontal ligaments. And what does it attach it to? The alveolar bone. So the periodontium, gingiva, cementum, periodontal ligaments, alveolar bone. Pretty easy, right? That's the 4 tissues of the periodontium. Sounds familiar, right? This is in chapter 1. We're getting it. This is a pop question, real fun. Where do popcorn kernels get stuck? The sulcus, right? We know this. The sulcus, it's probably not going to be on the test, but it's just a fun fact to tell your patients. Yeah, that little place where your popcorn gets stuck, it's called a sulcus, you know? It gets a little irritated, and it could cause some inflammation if you're really irritated enough. So, all right, ready? What are the 3 divisions of gingiva? Divisions. When you use a word like this, it could be anything, right? Like 3 divisions of gingiva. What is that? Okay, the 3 divisions of gingiva. What are the 3 kinds of gingiva that we have in our mouth? So, we mentioned attached gingiva already. So, we know we have attached gingiva. We have free gingiva, so it's the turtlenecks, right? So you have the attached gingiva, the free gingiva, and then they're asking for the interdental papilla, so the interdental gingiva, okay? We're talking about periodontology, so we're going to focus on that, okay? There's like alveolar mucosa, all that stuff, but gingiva, okay? So you have the attached gingiva, the free gingiva at the top, little turtlenecks, free gingiva, right? And then we have the interdental gingiva, the papillae, right? Interdental, sharp like a knife. So we have attached, free, and interdental, okay? That's easy. We know that. So what are the 3 divisions of the gingiva? We have attached gingiva. That's an easy one. We have our turtleneck, our free gingiva, and then in between the teeth, we have our interdental gingiva, our papilla. This is easy. All right, so what is the outer surface of gingiva composed of? All right, beautiful. Okay, so what is the outer surface of gingiva composed of? What kind of cells, right? So the outer gingiva, we want it to be a little tough, right? I don't think that's going to matter for this definition, but just keep that in mind for later. So our gingiva, the outside of it, is made of a stratified squamous epithelium. We're going to break that down as well, okay? I have flashcards over this, so I don't want to get too ahead, but let's just do it. So our gingiva is stratified squamous epithelium. So stratified, what that means is just a bunch of layers, multiple layers. So of course we want multiple layers there, right? We want it to be protected. We need to protect our roots, protect everything. It's stratified. We want plenty of layers. Stratified is layers, okay? So we have stratified. Squamous is like the shape of the cells. So squamous, I think of squash, so they're flat cells. So we have layers of flat epithelial cells on the outside of our gingiva, okay? So we have layers of flat cells, stratified squamous or squashed epithelium. I should have got that allergy medicine from Danya today. Okay, so one more time. The outside of our gingiva it consists of what type of cells? The question technically is, what is the outer surface of gingiva composed of? Because he might use some big terms like that. To me, that's like, wording it like very professional. What is the gingiva composed of on the outside? So stratified squamous epithelium, layers of flat epithelial cells, right? So we have that outside. So what lies under the epithelium of the gingiva? So what is under that stratified squamous epithelium? Let's find out. Connective tissue. We know this. So we have that layer of cells. We've got that basement membrane. So we've got the connective tissue right under there. And the connective tissue actually has a name. So we remember seeing the epidermis, how it goes from the, the skin, the epithelium and stuff like that. So we've got the epidermis and the dermis. And in the dermis is all of those connective, the vessels, blood vessels. It supplies the skin kind of ordeal. Same thing, same concept with our gingiva, right? So we have our outer layer is our what? Stratified squamous epithelium. Right? Layers of flat cells, and underneath that is connective tissue where all of the blood vessels are located that supplies the top layer, okay? So the connective tissue, like I was saying, has another name, okay? Oops, I banged my elbow. So the top layer right here is going to be our stratified squamous epithelium. This is our connective tissue, okay? This one right here, our connective tissue, is called lamina propria. Lamina, lamina propria. Propria. Lamina propria. Laminopropria. Laminopropria. You got to say it a few times. But basically connective tissue. I'm not sure which word he'll use, but just know that the connective tissue is lamina propria, okay? Lamina propria. How come? Layer underneath. I'm not sure how we'll remember that, but we'll come back to it. Okay, moving on. What is stratified? Okay, we know this. We just went through this. So stratified is technically a number of cell layers, multiple layers. There are several in gingiva. Awesome, we know this. We know that the outside, the epithelium of the gingiva is stratified, squamous epithelium. It is layers of flat cells, right? So what is stratified? Layers of cells, a bunch of layers. And the gingiva has several to protect itself, okay? We don't want it thin. If it was thin, our roots would show, right? We want it thick. We want thick skin there, thick gingiva there. Okay. What is squamous cells? Wow, we reviewed this already too. So squamous cells is the shape, squashed cells, right? So they're squashed cells. The shape of the epithelial cells are flat. They're squashed. Technically, they are like scales. They are flat like scales, okay? Fish. Our mouth is wet. It's like a little ocean. I guess back to the Little Mermaid. Here we go with the, carcinoma. Okay, but the shape of the cells, the shape of the epithelial cells, squamous. What is that? Squashed. So it's flat, like scales on a fish, okay? Squashed flat cells. That's all that is. Moving on. All right, so what are all mucous membranes in the body lined with? Oh my gosh, we have a winner. Okay, so what are all mucous membranes in the body lined with? Can you take a guess? Stratified squamous epithelium. So this is cool. So our mouth is part of the digestive tract, right? And all of that goes down. So basically all of that is going to be the same type of tissue, all the same kind of cells. So we have in our mouth, our gingiva is stratified squamous epithelium, and so is everything that has the membranes, the mucous membranes. Our mouth is wet. We just think of all mucus, wet, things that try to slide around. I don't know if that works, but our cells have to be flat so things could glide down our digestive tract. So let's see. What are all mucous membranes in the body lined with? Stratified squamous epithelium. Say it out loud a few times, because when you get used to saying it out loud like that, it's like it just gets stuck in your head. It's like it's just normal to talk about stratified squamous epithelium. Okay, so who knew it'd be so easy to talk about? Stratified squamous epithelium. If there's another kind on the test, it's not going to be the answer, because we know about our stratified squamous epithelium. Okay, we know exactly what that is. It's going to be layers of flat cells, okay? So, excuse me. So, all of those membranes, all of the mucous membranes have the same as our gingiva. Just think it's wet and everything that it's connected to is also wet, okay, which is mucous membranes, okay? So, also, you will find stratified squamous epithelium on the palms, okay? It's hard, it's rough. We need that protection there too. I've got a cough again. Oh my gosh. Okay, I think I got it out that time. So, allergies are really acting up. I apologize. So, we have our palms. We need protection there too. When we slide on things, we fall. We need that thick layer there. So, stratified squamous epithelium. And on where else is thick? Our soles of our feet, right? Our mouth, our digestive tract, and our eyeballs. We need protection there too, don't we? If something gets in our eye, we need thick skin there. So just think thick skin. We need thick skin on our gingiva to protect the roots. We don't want those exposed. We know what could happen. We want all of our mucous membranes to be protected. So our digestive tract, mouth, digestive tract, we have our palms and our soles of feet. We need protection there, What if we had no shoes? We need protection for our feet. That's very important. We can't walk without our feet. Well, we'd have to modify ourselves, but it's okay. And then our eyeballs. We also need thick skin on our eyeballs in case we got something in our eye. So, stratified squamous epithelium is found where? On the gingiva, in the digestive tract, soles of our feet, palms of our hands, and our eyeballs. Pretty easy, right? We need some thick layers of cells there to protect ourselves, okay? Pretty easy. Moving on. All right. So what lies at the base of a sulcus? Well, we know what a sulcus is. You've got your tooth. This is my free gingiva, and this little space there is our sulcus, right? We know what a sulcus is. So what lies at the base of our sulcus? That's right, the junctional epithelium, right? When we probe, when we see the blanching, when we're probing, that's what we're touching is that junctional epithelium. That's where the tightness occurs. That's where all of the periodontal ligaments are underneath, holding it nice and tight. I'm not sure if that's accurate, but we know that the sulcus, once you hit the bottom, is the junctional epithelium. Junctional epithelium, so it junctions. Okay, there's your free gingiva, here's your tooth, that little space, and then down here is your junctional epithelium. We know this, okay? So at the base of the sulcus is your junctional epithelium, right? Okay, are you still hanging in there with me? We're doing great, okay? We're doing great. All right, so the free gingival tissue meets the tooth in a thin, rounded edge called dun 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 dun. Okay, it's just a big question, right? So let's think this through. The free gingival tissue. Oh yeah, here we go again. So we had our free gingiva just hanging off the tooth. Here's our sulcus, here's our tooth, right? So the free gingiva meets the tooth down here in a thin rounded edge. What is that called? So down in the junction epithelium, where does that meet at? How does it meet? Rounded edge called bum ba da bum. Oh, the gingival margin. What a question. What kind of question is that? We know what the gingival margin is, okay? So the gingival margin follows the contours of the teeth, creating the wavy outline. So, well, we know that. We know that. So the gingival margin follows the contour of the teeth, creating a wavy outline, right? So a wavy outline of the gingival margin. Beautiful. That was just a silly sounding question, right? So the free gingival tissue meets the tooth in a thin, rounded edge called the gingival margin. We know that. That's just a weird question. Okay, here we go. You ready? Explain free gingiva in health. So, when the free gingiva is healthy, what do we want to know? We want to know the boundaries. So, the free gingival groove to the gingival margin. So, I have a picture. Okay, I have a picture. Woohoo! Okay, so you see this demarcation line right here? That is going to be your free gingival groove, right? And we want to know where the boundaries are of free gingiva. Well, free gingiva is from that free gingival groove up to the gingival margin, right? All of that should be free gingiva. It's the turtleneck, right? All that is our free. So from the free gingival groove to the gingival margin. And that is our free gingiva boundary, right? We know this. That's easy. Okay, this says the margin is 0.5 to 2 millimeters coronal to the CEJ. So what that means is, here's the CEJ. We'll call the bottom of these teeth the CEJ, right? So really the interdental papilla right there. So we want the free gingiva where we stick our probe down in and go around the tooth, right? When that blanches and hits the junctional epithelium, we know we only want 1, 2, and 3 millimeters, right? That's healthy. So the margin for the free gingiva is going to be little. We want it to be small. This says, his PowerPoint says 0.5. So 0.5, instead of 1 millimeter probe, 0.5 to 2. So that's that. Free gingiva. We don't want much of it because if it was, it would flap in the wind. We want it just little enough, but just open enough, you know. So 0.5 to 2 millimeters. Free gingiva. Okay. So what kind of surface is the free gingiva? It's smooth, right? It's a smooth surface. There's no stippling. There's no stippling in the free gingiva, okay? Let's see. I don't know if you could see it, but the free gingiva is smooth, it's free, it goes with the flow, it's free gingiva, it's smooth, no stippling, it's just a little bit, so just a little 0.5 to 2 millimeters, it's free gingiva. It's just a small, from the free gingival groove to the gingival margin, just a small little piece. We don't want it to flap in the wind, we want it to be small, it's smooth, no stippling, and we do want it to be strong, right? So we know it's stratified squamous epithelium. We want it to be strong enough that nothing can hurt our roots, nothing can get down in there and hurt it. So what kind, how do I word this? Is it keratinized or is it not keratinized? So we don't want it to be susceptible to any disease, right? Because if something is non-keratinized, it's softer, it's more, I would say permeable, but maybe not. It's that's just a word I like to use because I like to say it. But non-keratinized is very susceptible to disease. It's not really protected. That keratin is like a hard layer that protects it. So we know we have layers of flat cells. We want to keep our roots protected. We don't want our free gingiva to be susceptible to disease. Everyone would have embrasure spaces if that was the case. So our free gingiva is keratinized, okay? Basically, everything outside of the sulcus is keratinized, okay? It's so we can chew our food. Things don't scratch it up, tear it up so terribly, you know? So everything outside of the sulcus is going to be keratinized. Just know that, okay? Easy breezy. Okay, so free gingiva. That's just going to be smooth, no stippling, just a little bit of something from the free gingival groove to the gingival margin, 0.5 to 2, real easy, right? Keratinized because we don't want it susceptible. There you go. You in depth can explain a free gingiva now. Okay, turtle. All right, so how do you clinically measure the width of attached gingiva? Well, darn, we gotta measure that too. So the attached gingiva, we know what that is. How do we measure that? So this says measure the sulcular depth to the mucogingival junction. Okay, we could break this down. So measure the sulcular depth. So what we're doing there is probing our sulcus, right? So we want to know what that is. What does that measure, right? What down there, what does that measure? Measure the sulcular depth, okay? And then once you get that reading down there, you're going to measure to the mucogingival junction where the loose and the attached gingiva meet. So it's literally just the bottom of the sulcus to the soft gingiva. Okay, that's how you measure that. That's pretty easy, right? Pretty easy. Oh, here's another picture. So down in the sulcus, so we have it right there, and then we have to right there. Okay, so you just want to know the bottom of the sulcus to the free, not the free gingiva, but the, what's that called? Mucogingival junction right there, where the loose alveolar mucosa meets the attached gingiva, this demarcation line, okay? This one to the bottom of the sulcus. That's all we want to know. We're not going to add this. We're not going to add that gingiva. We just want to know down here. We're like, okay, if that's a 4, we're going to go here. So we know that's 4. So we'll go here to here. And that is the width of our attached gingiva. That was on the PowerPoints. I hope he doesn't ask about that because words can get a little confusing. But just know if that's pretty easy. If you're just measuring this, it's from the base of the sulcus to that demarcation line. That's your attached gingiva. And you know, if we didn't have much there, the probe would go all the way down straight to the alveolar mucosa. Nothing would be holding our teeth in. So that is important, I guess. Okay. Attached gingiva is attached to what? Attached gingiva is attached to cementum and the periosteum. We're going to get very, very familiar with the periosteum. So attached gingiva attaches to the cementum. Well, that makes sense. We see, mine's great. They're really prominent. I don't know if you can see it. It's pretty gross to just put my teeth up there. But, you know, you can feel your roots in there, you know. So your attached gingiva is attached to the cementum because what's around the roots, right? So attached gingiva is to the cementum and the periosteum. The periosteum is the tissue that covers the bone, okay? covers the bone. So it's really cementum and bone, but cementum and periosteum. Cementum and periosteum. Okay. This is going good. This is not so bad. If we go back and we review what we just know and we get that in our head, boom, chapter 1's going to be so easy for us, okay? So, give attached gingiva in health. So we have to explain attached gingiva. Well, we pretty much know attached gingiva, but he has some things on the PowerPoints. This one I believe is starred because I have some things that are highlighted. So to me indicates need to know it. So we know that the attached gingiva is attached to cementum and periosteum, okay? What does periosteum cover? The bone, okay? The bone. Periosteum covers the bone, okay? You don't want bone on bone on bone. You need some tissue in there. So bone, periosteum, okay? So attached gingiva attaches to the cementum and periosteum. And the attached gingiva, we know anything outside of the sulcus is what? Keratinized. We need it to be strong to withstand all of our food and the mechanical abrasion stuffs that we do and stuff. We need it to be strong. So this is highlighted. So your attached gingiva on the facial is widest at incisors and narrowest at first premolars. I don't really know what that means, but we're going to roll with it. We'll have to review this a little bit more. So, in health, our attached gingiva is going to be on the facial wider at the incisors. I guess here, that's pretty wide. I think it's pretty wide. And narrowest at the premolars. Those do get pretty long. You would think the canines are pretty long, but it's still up there. So the widest of the attached gingiva facial is at the incisors, and it gets narrow at the first premolars, okay? Now it's kind of backwards on the lingual. Let's think about this. So on the lingual, it's widest at the molars on the inside, and then it gets narrowest at the incisors. Okay, attached gingiva, it'll be fat here, so wide here, thin at the first premolars, and then on the lingual, it's going to be fat at the molars, and then behind, we know behind that lingual in the back, that lingual anterior, it's just a little itty bitty thing, right? So it gets narrow there on the lingual. So this one we'll just have to review. Facial, fat, narrow first premolar. Lingual, fat, narrow at the incisors. It's backwards, okay? We know it's keratinized. We want it to be strong. And on the attached gingiva is where you will see the stippling, okay? And I think I may have a flashcard on what stippling is, but it's because of the connective tissue and how it connects. We'll get to that too. I think there is some stuff about that. So, awesome. Whew, let's take a break. So, just a breath, not a break. We got to keep going. I don't have a pause. But the attached gingiva, we know that now. We know it's fat here, thin at the first premolar, fat lingual molars, thin behind our incisors, right? Attached gingiva, we know it's keratinized, and that's where we will see the stippling. That's all we really need to know. What is it attached to? Cementum and periosteum. Boom, if you can get that down, you are solid on your attached gingiva. Okay? Next, here we go. Explain stippling. Okay, so stippling is only in 40% of adults, okay? Stippling, 40% of adults. How can we remember that? I don't know. Stippling, 40% of adults. We'll just say it a few times. Stippling, 40% of adults. Stippling, 40% of adults. Oh, stippling, 40% of adults. Woo! Okay. And it's most prominent. Where is stippling most prominent at? It's most prominent on the facial anteriors. Well, that's easy. We know we're going to see stippling here if we see stippling, you know? So here, that's where we're going to see it. Where is stippling most prominent at? The facial anteriors. How many people have it? 40% of adults. And then stippling can be present in both disease and health. So just because they're stippling doesn't mean they're healthy. It doesn't mean they have disease. It's just the way the connective tissue is attached. Causes a stippling, okay? Everybody's different. That's why it's only in 40% of the people, 40% of the adults. prominent here and here, facial anteriors, and it can be present when? In disease and health. It doesn't matter if you're healthy, doesn't matter if you have disease, it has nothing to do with it. It has to do with how your connective tissue attaches to the epithelial tissue, right? Okay, we're doing great. We're almost halfway there. But that'll be chapter 1, and then we'll be good. You review this, and then you move on, you know. Once you know all this, you're good. You're golden. All right, so colors of attached gingiva. All right, so we know it's various shades of pink. We know this. Gingiva is various shades of pink, pale, or coral, and it may be pigmented. We know this. Pigmentation is normal in darker skinned people. From light brown to black may be the pigmentation that you see, but it's totally normal. Everybody's different. So various shades of pink, pale, or coral, or it may be pigmented light brown to black. No biggie, right? We know this. Let's move on. What is a col? We know what a col is. So it's a valley concave depression. Concave, not convex, concave. It's making a little burrow, a little cave, okay? Where do the bacteria want to hide? They don't hide. They don't want to be out in the open. The bacteria want to be down in the cave, okay? So it's concave. The col is concave. And we know it's interproximal of the teeth, directly apical to the contact. So we know down here we have the contact. We know where they're hiding, down in the concave, right? They're hiding in the concave underneath the contact area, interproximal. It's pretty safe there. Wouldn't you think? If you're a bacteria fittest, of the survival of the fittest, you'd want to hide down in there too. You're not going to be able to reach that area easily. So the col is an area of plaque accumulation. We know this. Plaque wants to get down in there. That biofilm, those bacteria just want to bury down in that concave col, right? And it's non-keratinized. Why is it non-keratinized? Yes, it's outside of the sulcus, but it's non-keratinized because it's like a little cave, and those bacteria are going to go there, and that little non-keratin area is what's susceptible to disease. This area is where periodontal disease starts. So down in the col, they know it's an easy target. They know it's not keratinized. It's nice and soft and good down there, you know. So they're going to go ahead and burrow down in this cave, and they're going to start attacking the gingiva and all the stuff that they do. So a col, valley-like concave depression, interproximal beneath the contact. Here we are in this little concavity underneath the contact. Area of plaque accumulation, we know this, and then non-keratinized because it's very susceptible to periodontal disease. And if the teeth is missing or there's recession present, the col is absent. It can only be there if you have papilla there. And if you are missing teeth, you're not going to have papilla. You know, it's just not there. Trust me, it's not there. Okay, so col is absent if teeth are missing or recession is present. You need that papilla to make that concave. We know this, see? I'm just trying to explain it in depth. You never know. Something might just, wow, I really get that now. Okay, so what happens in interdental gingiva? Oh, what happens if interdental gingiva is unhealthy? So if interdental gingiva is unhealthy, we know what's going to happen. So in disease, there are open spaces because interdental gingiva is missing. So in unhealthy, we know healthy is a sharp, knife-like, right, papilla. And in disease, it's going to apical migration of the junctional epithelium, right? If that bone is resorbing, if there's some disease and that stuff kind of just is resorbing, it's going away. That papilla follows that bone, right? If there's disease, there's going to be open spaces between the teeth and brazier spaces. So interdental gingiva is missing if there's disease. It just recedes and it's gone. There is none between the teeth. Pretty easy, right? Okay, explain gingival sulcus. Is this all you got, Dr. Crosby? Geez, we know this. We got this. So we know that the sulcus or crevice is the space between the free gingiva and the tooth surface. We know that. The tooth surface could be enamel, cementum, or both. So this will represent cementum, this will represent the enamel, and if they had a little bit of recession there, it could be both, or it could be right there. You know, it could be both. It could be any of that. No, both of those could be in the sulcus. Okay. So I guess, I don't know. If they don't meet, it will be. Okay. So anything outside of the sulcus is keratinized. So inside the sulcus is not keratinized. We'll get deeper into why. You know, there's fluid in there, that sulcular fluid, but it's non-keratinized. And we need that fluid to pass through and, you know, between our skin and stuff. So that's permeable right there. But we're just going to focus, it is non-keratinized. It's permeable down here, so the fluid could go in and out and all that good stuff, the crevicular fluid. So right here, non-keratinized, and it is less resistant to bacterial invasion. Well, we know that. Anything that is non-keratinized is going to be less resistant to bacterial invasion. It's going to be easy to get an infection. And it's asking for the health. We know in health, the sulcus measures what? 1 to 3 millimeters. In disease, it is more than 3 millimeters. It's a pocket. Okay, we know this. We're cruising. Is the sulcus empty or is it filled? Well, it is a fluid-filled space. The sulcus is a fluid-filled space. It is not empty. So get that in your head right now. The sulcus is not empty. It is fluid-filled, filled with gingival crevicular fluid, that GCF, okay? So you have fluid all in there, and that's what feeds the bacteria. We'll get into this later, but you need that. You need that fluid in there, okay? Because we do have healthy bacteria too, and they need to eat, don't they? But not in our sulcus, okay? Anyways, there is gingival sulcus, gingival crevicular fluid in there, okay? So your sulcus is not empty. It has fluid in there, okay? When it's healthy, there's less fluid. And in disease, there's more fluid, okay? You've heard in disease, the bacteria poop acid, this and that. So just think, if it's disease, they're pooping acid, they're putting more fluids in there. Not that it's the same kind of fluid we're talking about, but that's how you can remember. Is in disease, there's going to be a little extra fluid in there, okay? So, what is a periodontal ligament? Wow, we know this. Chapter 1 is going to be golden. We got this. So, what is a periodontal ligament? Okay, it's a specialized connective tissue. Well, that makes sense. It does connect things to each other. That attaches the tooth at the cementum to the alveolar bone of the tooth socket. Oh my goodness, we know this. What is a periodontal ligament? It's a specialized connective tissue that attaches the cementum to the alveolar bone to hold the tooth in, right? We know this. And this is highlighted right here. It says tooth is cushioned from occlusal forces during mastication. We know this. So when your tooth is in your little socket here and you've got those little rubber bands holding it in there, the reason why it's only suspended and, you know, it's not bone on bone, because if we chewed, that'd be very, very traumatizing, bone on bone. So it's suspended so it can have those occlusal forces so we can chew. That's all that means. Tooth is cushioned from occlusal forces during mastication, during chewing. That's so easy. We know what periodontal ligaments are. All right. So what are the 5 functions? Now this one's star, starred, okay? So the rest is easy. We can get this. So this one we're going to focus on. This is one we really need to know. So what are the 5 functions of the PDL? Okay. Well, let's think this through. So the periodontal ligaments, right? What do? They suspend and maintain the tooth and socket, right? That support, they help support the tooth. Well, let me go this way. They help support the tooth, okay? So this is my alveolar bone, and this is my cementum, right? So they're attached. So it helps suspend the tooth into the socket. That's supportive. It helps support the tooth, okay? Now this says sensory. So we know supportive, it helps, suspends and maintain the tooth in the socket. Now sensory, provides pressure and pain sensory to the tooth. Okay, well, how can we remember this? So periodontal ligaments also indicate sensory because it provides pressure and pain sensory to the tooth. Well, if they're embedded into the cementum, right? Maybe there's some dentin inside of that. I don't know. I'm just going with the flow here. So there's some dentin inside of there. That's where the dential tubules are. That has the odontoblastic process that transfers from the pulp to the outside and causes the pain and stuff. So that makes sense. So the periodontal ligaments are into the cementum through the dentin that has those dentinal tubules to the pulp, right? So we have supportive. We have sensory, because why? Because that pressure and pain senses all the way through the cementum, through the dentin, into the pulp. Okay, so supportive, sensory, and then we have nutritive, okay, provides nutrients to cementum and bone. Well, okay. All right, well, I guess we got to feed them, right? We got to feed them. I don't know exactly how, but we will get there. I'm sure it's deeper in perio. So we have the suspension, so the support. We have the sensory, so into the cementum, dentin, dentinal tubules, pulp. So we have support, sensory, and now we have nutritive. So we got to feed everything, right? So the periodontal ligaments help feed the bone, help feed the cementum. That's exactly what it does. Don't know how yet, but we will. Just know that it does. It's nutritive. So it helps feed the bone and the cementum. It's helping. Okay, the next one. There's only 2 more for this. Formative. Builds and maintains cementum and alveolar bone of the socket. All right, so the PDL does this. Okay, well, support, sensory, we have nutritive because it's got to feed them, and now formative, builds and maintains cementum and alveolar bone of the tooth. I don't know about this one, but it's on the PowerPoint, okay? So we're just going to know it. Formative. I guess, if there's a lot of pressure, it makes the bone grow and the stuff retract and all that crazy stuff. So builds and maintains cementum and alveolar bone of the socket. We want everything to be happy because if those periodontal ligaments are stretched, things are going to go crazy, right? They are rubber bands and they want to be at a certain length. So formative. They will form some stuff to happen. And then remodeling. Okay, remodels the bone in response to pressure or tension caused by orthodontic treatment or occlusal. So formative and remodeling are kind of like the same thing to me. So formative builds and maintains cementum and the bone, and then it remodels. So it's basically the odontoblasts and the odontoclast. So formative and remodeling. Okay, we'll just go with that. Okay, so we have support, sensory, nutritive, formative, and remodeling. Okay, and like I said, I hope you have your stuff with you too, so you can go through this with me. It might make it a little easier. What is Sharpie's fibers? We know this. Sharpie's fibers goes into the cementum, and in there is the Sharpie's fiber, and into the alveolar bone. Yep, ends of the PDL fibers embedded into the cementum and alveolar bone. Sharpie's fibers. She really helped us, didn't she, Mrs. Sharp? We love Mrs. Sharp. She helped us. Sharpie's fibers is in the end of each. She helps us connect to the other stuff. Well, I don't know. It's in the ends, but what is cementum? We know what cementum is, okay? It's a thin layer of hard mineralized connective tissue that covers the surface of the root of the tooth. And we know it's light yellow, okay? So this is cementum. It does not remodel like bone. We know this. It resists destruction under pressure. This is all underlined and bolded. So cementum does not remodel like bone. Bone does all the remodeling, doesn't it? So it does not remodel like bone. It resists destruction under pressure. It resists destruction under pressure. Bone resorbs before cementum, making orthodontic treatment possible. So we just really need to know about cementum that it does not remodel like bone. Bone is going to remodel for orthodontic treatment. And it resists destruction under pressure. It doesn't want to destruct. That's how I'm taking that. I don't know if that's right, but we're just going to roll with it. All right. This is an easy one. Does cementum have its own blood supply? Let's think about this. Cementum, does it have its own blood supply? No, it does not. Nope, it receives oxygen and nutrients from the PDL. So, yeah, we know that the PDL is nutritive, right? It's got to feed both of them. The cementum can't feed itself, right? So, no, it does not have any blood supply because it gets it all from the PDL. The PDL kind of helps them both out. All right. All right, so it has no nerves and feels no pain. It gets all the nutrients and oxygen from the PDL. All right. The cementum also protects the dentinal tubules from the hypersensitivity. That is starred. It protects dentinal tubules from hypersensitivity. Well, we know this. We have the cementum, and inside the cementum is the dentin, and in the dentin is those tubules with the odontoblastic processes that can receive those messages straight to the pulp, right? So that cementum covers that. If those dentinal tubules were exposed, they'd be hypersensitive. So good, we know this. We got this. Cementum protects dentinal tubules from hypersensitivity. All right, hang with me. We are almost there. Exposed root plus loss of cementum equals hypersensitivity. We know this. Keep it moving. What are the layers of the alveolar? This one we got to study, okay? This is the bone, okay? This is one that we're not too familiar with, but we should know. So what are the layers of the alveolar process or bone? Okay, so we have 4 layers, right? We have 4 different parts to the bone, our alveolar bone. We're going to learn this. So we have our alveolar bone proper. So we have the proper, right? The cribriform plate. So I'm proper and I want to eat off of the cribriform plate. I'm the alveolar proper, aka cribriform plate, okay? And remember what a cribriform plate does. So it's got those holes in it so that the blood vessels can go through and all that good stuff. We'll get back to that. But alveolar bone proper is the cribriform plate. Okay, he wants to eat off the plate because he's proper. All right, and then we have our cancellous bone, which is aka spongy bone. Cancellous, spongy bone. We want to cancel out spongy gingiva, right? We want to cancel out spongy bone. Well, we don't want to cancel out the bone, but we want to cancel out spongy gingiva because that's gingivitis. So think cancel out the spongy, okay? Cancel out is spongy. So cancellous bone is spongy. And then we have cortical bone, which is the outside bone. And we'll get more deep into this, but cortical bone is just the outside of the bone. It's the outside layer. And what's on the outside of bone? Periosteum. Boom. Those are your 4 layers of the alveolar bone, okay? You have your alveolar bone proper, who eats off of the cribriform plate, okay? And then you have your cancellous bone, which is spongy bone. We want to cancel that spongy gingiva. Then we have cortical bone, which is the outside, just cortical. You know, courtyard, it's outside. Cortical, it's outside. And then outside of the bone is the periosteum. Periosteum. The osteum is like a tissue, and peri is around. So the tissue around the bone, periosteum. Okay, so what is the periosteum? A highly vascular connective tissue sheath covering the external surface of all of the bones. We have it everywhere. So it's highly vascular. Why? Because we have to, think about it. The bones, inside of the bones, they make their bone marrow, which produces blood cells, right? So if that's right outside of the bone, don't you think it'd be highly vascular? That's how all the blood gets out to all the other stuff, right? So your periosteum is highly vascular, okay? So it's a highly vascular connective tissue. Why is it connective tissue? Well, it's down deep, right? And it connects things to other things, right? So highly vascular connective tissue sheath covering the external surface of all of the bones. We have it everywhere, okay? What is the alveolus? Well, we know what the alveolus is. The alveolus is the actual socket or the hole that is shaped around the dental root. So the hole is just the alveolus. We know the alveolar bone, the alveolus. So think of the hole. So it makes kind of like a U shape, doesn't it? So alveolus is the U hole. You know, lus has a U in it. The hole looks like a U. I'll even show you. See here? I don't know if you could see that, but it's like a big U there. So the alveolus is the socket, the actual hole, okay? All right, alveolar bone proper. What did we say the AKA name was? It was the cribriform plate, right? So it appears to have large pores where the blood vessels connect structures, right? It allows blood vessels, lymphatic vessels, and nerves from the cancellous bone to enter the PDL. Awesome. So let's say it again. It allows blood vessels, lymphatic vessels, and nerves from the cancellous bone to enter the PDL. Okay. It appears to have large pores where the blood vessels connect structures. Okay. So this is the thin layer of bone that surrounds the alveolus. Okay, so we have the alveolus, which is that U, so it's the actual socket itself, so the hole, and that lining of the hole is going to be your alveolar bone proper, your cribriform plate. Well, that makes sense. We have to have those nerves or the blood vessels and stuff feeding the tooth itself, right, up under the apical foramen and the bottom of the tooth, right? So we have the U shape is the alveolus, and then that thin layer that lines each alveolus is going to be your alveolar bone proper, which is also the cribriform plate, which means that blood vessels feed that little area, right? Well, they got to come from somewhere, right? And they come from the cancellous bone. When you see cancellous is spongy. We've seen spongy bone. It's a holy bone. So we've got all those vessels going through all those bones. Can you picture it? All right. So it's the thin layer of bone that surrounds the alveolus, the socket, the hole. It allows blood vessels, lymphatic vessels, and nerves from cancellous bone, so the spongy bone, to enter the PDL. So boom, okay, the PDL. Yeah. And then, so that's how it goes. So, okay, we've got the, of course, the spongy bone, and then we go into the alveolar proper, into the alveolus, and then it's the periodontal ligaments are in there, right, around the root and stuff, so they get all the blood, and they supply the bone, like, I don't know, I guess it's like a big circle, but follow with me, okay, you hear me? All right, so there's an x-ray name for the alveolar bone proper. So remember, this is the lining that lines the socket. On the x-ray, it's called lamina dura. Okay, lamina dura. It's the lining of the alveolus. Remember, it's that thick white line that, when you get a tooth taken out, there's a line left. Or sometimes if the tooth's there, you can still see it, but it's a white line that just lines the alveolus. That's the lamina dura on an x-ray. Okay, we're almost there, guys. Cancellous bone. So this is your spongy bone. We want to cancel out the spongy gingiva, right? Cancel it out. This is your spongy bone. They say it's a lattice-like bone. So lattice, it's kind of like holy, spongy looking. Yeah, lattice, like a sponge. It's kind of holy, looks like that. That's why I call it spongy bone. So it's lattice-like bone that fills the inner portion of the alveolar process. Okay, let's think about this. So we know if the outside of the bone is cortical bone, the inside that lines the alveolus is our alveolar proper. Everything in between is going to be our cancellous bone, right? So it lies between the cortical bone and the alveolar bone proper. And it is filled with bone marrow. It is filled with bone marrow. That's how it gets through into the alveolus, through the alveolar proper. It's spongy bone. It's all filled with the bone marrow. It produces the blood cells. Yeah, that makes sense. That's awesome. So it's got a whole bunch of bone marrow in the spongy bone. Spongy's awesome. Okay, we love spongy bone. We want the bone marrow. We want all the cells. So we've got all these cells in the spongy bone. Bony trabeculae oriented around the tooth to support the alveolar bone proper. That's not highlighted. That's just extra. But just know that cancellous bone is spongy bone. It's lattice-like bone that fills the inner portion of the alveolar process. When they say inner portion of the alveolar process, we know what that means because cortical is the outside, alveolar bone proper is the lining of the alveolus, the hole, and everything in between is cancellous. And we need somewhere to get the blood, so there's all kinds of bone marrow in there. Awesome. We are almost done. I know it's almost an hour, but we're learning. We got to do this. Cortical bone forms the outside wall of the mandible and maxilla. On the facial and lingual, we know this. It supports the alveolar bone proper. Okay, supports alveolar bone proper and gives support to the socket. Well, that makes sense. It's the outside. We need it to be stable. And then it says the alveolar crest is the most coronal portion. Well, that makes sense. The alveolar crest is the most coronal portion. Yeah, we know this of the cortical bone, right? Okay. It's all the outside of the bone. Okay. So, what does the periosteum consist of? Well, wasn't the periosteum very vascular? Let's see. All right, it's a layer of connective soft tissue covering the outer surface of bone. We know this. So, what does the periosteum consist of? It consists of a fibrous outer layer, collagenous tissue, and inner layer of elastic fibers similar to Sharpies. Okay, rewind. Boop. It consists of periosteum. It's a fibrous outer layer, okay? And then it has a collagen, collagenous tissue. So it's a fibrous outer layer. So we want it to be kind of thick on the outside, right? So the periosteum is a fibrous outer layer, collagenous tissue. I can't say that word. And the inner layer is elastic fibers, similar to Sharpies. Well, that's cool. We know the inner layer, similar to Sharpies, we want fibers. We want it to attach to the bone, right? So how's it going to attach to the bone? It doesn't just lay there. Otherwise, it'd slide everywhere, right? So the inner layer is the elastic fibers, and the outer layer of the periosteum is going to be the fibrous outer layer, okay? And collagen. Fiber, collagen, that kind of stuff on the outer. And then the inside is elastic. Yeah, so it can move a little bit, but it doesn't detach, okay? And it contains blood vessels, lymphatic vessels, and nerves. We know it's highly vascular. All right, just a couple more, y'all. Alveolar crest. It's the coronal portion of the alveolar bone. We know this. It's going to be located 1 to 2 millimeters apical to the CEJ. So that's cool. So we know the sulcus, right? Well, the free gingiva is 0.5 to 2 millimeters. And the gingival epithelium, we only want to be no more than 3, right? All right, so the alveolar crest we know is below the CEJ. We could picture that. We could see it. Oh, alveolar crest. Can you see that? Alveolar crest. Our CEJ is going to be up here. Cemento-enamel junction. That's where the cementum and the enamel meet. And the alveolar crest is going to be down here. We know this. So it's located 1 to 2 millimeters apical to the CEJ. And we know the facial lingual contour follows the contours of the CEJ of the tooth. It all kind of is like a beautiful wave, okay? Everything follows the contour of the CEJ of the tooth, literally. Okay, so coronal portion of the alveolar bone is the alveolar crest. We got that. And it's located 1 to 2 millimeters apical to the CEJ. The CEJ is a really good landmark for a lot of things. Okay, 3 more, y'all. Interproximal bone. Well, interproximal bone is going to be your interdental septum. Okay. So this says, lies between proximal surface of 2 adjacent teeth. That's not highlighted, but what is, it's between roots of multi-rooted teeth. Interradicular bone. Okay, we got this. Okay. So basically what's happening, interproximal bone is going to be aka interdental septum. Okay, we know what a septum is, right? That's right in the middle. It's like in there. So it's between roots of multi-rooted teeth. Interradicular bone. Okay, interproximal bone, interradicular bone is between roots of multi-rooted teeth. Interdental septum, I guess, could be part of this too. Really not sure. We'll have to check on that. Moving on. Nerve supply to the periodontium comes from what nerve? These are important. Okay, so these, if you don't remember anything from this video, remember this, okay? nerve supply to the periodontium comes from what nerve? Branches of the trigeminal nerve. Okay, duh, trigeminal. We know is the 3 branches. Remember that? So nerve supply to the periodontium comes from what nerve? Our favorite nerve. So periodontium, our favorite nerve is the trigeminal nerve, number 5, right? Olfactory, optic, oculomotor, trochlear, trigeminal. Yep. Okay, so number 5. So cranial nerve, number 5, trigeminal. Branches of the trigeminal nerve supplies the nerve supply to the periodontium. Okay? Boom, got it. Blood supply to the periodontium comes from what artery? Okay? What artery is going to supply this periodontium? Internal maxillary artery. Okay, awesome. So internal maxillary artery. I don't know if you remember it, but we're going to remember it right now. Blood supply to the periodontium, internal maxillary artery. Okay? And that goes to the maxillary and mandibular teeth, because remember, there is no mandibular artery. There is none. So the internal maxillary artery, that's what supplies the periodontium. The blood, okay? Supplies the blood. Now, lymphatic system. Last one. The lymphatic system that drains the periodontium is submandibular nodes. We know the submandibular nodes. We know the nodes, okay? Submandibular nodes. This is what's going to drain the periodontium, these submandibular nodes, okay? We have deep cervical, so deep cervical, submental, and jugulodigastric, okay? We just need to remember those. So lymphatic system that drains the periodontium is submandibular nodes. Submandibular nodes. The deep cervical, the submental, and the jugulodigastric. I'll let you see it in case that sticks in your head better. Submandibular nodes, deep cervical, submental, and jugulodigastric. And guess what? That's it. That is all you need to know for chapter 1. So we broke things down so you can understand them if you didn't already. Hopefully it makes sense. But the things that you don't know, definitely focus on that. Like these last 3 are probably going to be on the test. That's why they were all highlighted. So we're doing great. Just keep reviewing. We're going to go one more time for these last 3 because these are 3 that we really didn't touch on much. So nerve supply to the periodontium comes from what nerve? Cranial nerve number 5, trigeminal. Okay. Blood supply to the periodontium comes from what artery? Internal maxillary artery, because there is no mandibular. And it does supply the maxillary and the mandibular, but it's internal maxillary artery. Okay, because arteries are red, it supplies the blood. Okay, lymphatic system that drains the periodontium is the submandibular nodes, right? So you have your submental, deep cervical, and jugulodigastric. But yeah, I hope you learned something. This is all of chapter 1. So this is all you need to know for chapter 1. I try not to miss anything. So study this, feel comfortable with it, and then move on. And I'll keep these videos coming. And I hope they're helping someone with something, okay? But I love you guys. See you later. I know it's a lot, but we're going to get through this, okay? Here we go, Perio. Let's get this A.